I think that we can start this new webinar of the International Academy of Cytology. And it's a pleasure, a very big pleasure for me to have with us today Professor William Faquin, that he is Professor of Pathology at the Massachusetts General Hospital, Harvard Medical University, and he is also head of head and neck pathology at the Mass Eye and Ear Infirmary in Boston. And he is a well-known cytopathologist and histopathologist, and today he's here to speak about the new version of Milan system for reported salivary gland cytopathology, what's new, the update, and that will come out soon, I hope. And it will be a great pleasure for us to have you here and also to have your talk recorded so that everyone can come back and look at your presentation on our website. So, Bill, please, you are more than welcome to speak about salivary gland, and we will have time at the end of your talk for a Q&A session. So, please, Bill.
Thank you very much, Massimo, for that very kind introduction. I love salivary glands, so I'm really excited to be here to share the news about salivary gland FNA and to include updates that we're making to the Milan system. So as Massimo mentioned, I'm Bill Faquin. That's me in my backyard with my bonsai collection. And I work at the Mass General Hospital and the Mass Eye and Ear Infirmary in Boston. And if any of you are ever visiting Boston, feel free to get in touch with me, and I'd be happy to show you around our department, and maybe we can grab a coffee or something. There are basically three take-home messages that I hope everybody gets from this presentation. Number one, that there really is a significant clinical role for salivary gland FNA in helping our treating clinicians to guide the management of their patients. And then number two, the Milan system, the second edition, and I'll tell you about the updates, really does provide a standard means for reporting our FNA results. And throughout all of cytology, we're trying to have standard reporting systems. And I think the Milan system does a pretty good job of that. And number three, very importantly, I'll tell you about ancillary studies, because nowadays, when you can, ancillary studies can really significantly improve the accuracy of your salivary gland FNA. So we all know that salivary gland tumors are quite heterogeneous. This is just these are just a few images in the background of FNAs of various salivary gland tumors, and they're difficult for surgical pathology as well as for cytology and for core biopsy. And that's, as we know, because there is a lot of overlap in the histologic and even immunohistochemical features of many of the benign and low-grade tumors, as well as among many of the high-grade tumors. So you might ask, what role is there for FNA? And that's what I'll be telling you about over the next 45 minutes or so. I just want to start by giving you a little bit of introduction, and then we'll get down into the granularity of the Milan system and the application of ancillary studies for salivary gland. So tumors of the salivary gland, they are uncommon. When they occur, more often they're in older adults, they're more common in women, and a majority occur in the parotid gland. These three colored circles here on this diagram represent three areas that I think all of us are very familiar with in doing FNAs, especially in this preauricular area, where generally the clinician says it's a preauricular nodule, but it's really in the parotid gland because that's where the bulk of the parotid gland is located. You may also get an FNA done in an upper neck nodule, and sometimes it's sent to us as a lymph node, but more often than not, it turns out that it's the tail of the parotid gland, which goes right down there at the angle of the jaw and maybe a little bit under the jaw. And then sometimes you'll do an FNA of a nodule in the cheek, and these are very often accessory parotid gland tissue that can occur along Stenson's duct, and you can see all the same tumors in that accessory parotid tissue that you would see in the parotid gland. There are more than 30 different epithelial tumors of the salivary gland recognized by the WHO. The majority are benign, and the risk of malignancy, and this is important, is basically inversely proportional to the size of the gland. So in the parotid gland, the largest one, only about 20% of the masses end up being malignant. In the submandibular gland, about 50% end up being malignant. And in the oral cavity, especially the minor glands, upwards of 80% or more will end up being malignant, sometimes as much as 90%. So it's important to keep that in the back of your mind when you're evaluating either an FNA or a core biopsy. Now, I've mentioned core biopsy because I don't really want to disparage it. I do think FNA is a very important tool, and we should be using it. We use FNAs at my hospital, and I think at most institutions around the United States and many in other parts of the world for the major salivary gland lesions. And we use core biopsies more often for the minor salivary gland lesions that maybe are a little more difficult to access by FNA. Fine needle aspiration, the advantage is that we can do an FNA and get a diagnosis oftentimes right there on the spot. So there's a much faster turnaround time, especially if the cytopathologist is doing the FNA. So again, very fast turnaround time. We can sample with multiple needle sticks various areas of the tumor, and the risk of complications like needle tract seeding or nerve damage are very low. I think the one sort of disadvantage of doing an FNA is probably the availability of material for ancillary studies. So you need to be very aware of that and try when necessary to get material for a cell block. And that's the advantage of doing a core biopsy, is that it's going to be a more reliable source of material for ancillary studies. But I really don't prefer core biopsies for the major glands. Okay, in terms of effectiveness, salivary gland FNA is fairly effective. If you're doing it by ultrasound guidance, the sensitivity is very high. The specificity has a broader range, and that's because if I'm FNAing a pleomorphic adenoma, the specificity is going to be really high because we do a great job with that. However, if I'm doing an FNA of something like an epimyopithelial carcinoma or a basal cell adenoma, the specificity is going to be a lot lower because that's where we get into that overlap that I mentioned among various salivary gland tumors. We do a fairly good job of distinguishing benign low-grade tumors from high-grade malignancies. And in the next slide, you'll see why that is important. The other thing that I'll mention is that for cases where our FNA does not give a specific diagnosis, our clinicians will often do a frozen section at the time of surgery. I like frozen sections for salivary gland, and it's been shown that combined, the frozen section and the FNA are complementary. Okay, so what's the rationale of FNA for salivary gland in terms of helping to guide the management? If it's a non-neoplastic lesion like chronic salidinitis, then the patient can just usually get clinical follow-up without surgery. If it's a benign tumor or something that might be a low-grade carcinoma, then that's telling the clinician, do a very limited resection of that tumor. If it's metastatic disease or lymphoma involving a periparotid or intraparotid lymph node, we do a great job at FNA at diagnosing METs to lymph nodes, as well as pairing our FNA with flow cytometry and diagnosing lymphoma. And if it's lymphoma, the patient can get a hem-onc referral. And then importantly, if we make a diagnosis on FNA of a high-grade primary cancer of the salivary gland, that's really an important thing for the clinician, because it gives them the green light to do a more radical resection. Maybe they'll do a nerve sacrifice and maybe even a lymph node dissection. So just quickly, let me summarize what are the clinical management considerations that we should keep in mind when we are doing an FNA of the salivary gland and reporting it. The clinician wants to know, does he need to do an operation on this patient? So whatever we tell him, it's going to guide him to whether he needs to do an operation or not, and what kind of operation should he do? Should he do a radical resection, or can he just do some kind of superficial parotidectomy, for example? And is a neck dissection necessary? Is this a tumor or something that's going to involve lymph nodes in the cervical chain, and maybe he would need to do a neck dissection? And very importantly, is this an aggressive cancer? Is it an adenoid cystic carcinoma where they may need to sacrifice a facial nerve? And obviously, that's a big step, and that's a very important thing in terms of the patient having the facial nerve sacrificed. So the information that we give the clinician can really help in determining and answering these different questions. And for difficult cases, that's where we need to make sure that we get material in a cell block generally for ancillary markers, or in combination with the FNA, you may go back and do a core biopsy for ancillary material. Okay, so that's a little bit of background to salivary gland sampling. So let's talk about the reporting system. Why do we need a reporting system for salivary gland cytology? Obviously, we want uniformity in the way that all of us around the world are providing our diagnosis to the treating clinician. So you have a patient come in who has a salivary gland mass, and it's decided that a fine needle aspiration is warranted. We're going to do the FNA. We're going to look at it under the microscope. You may or may not make a cell block and do ancillary studies depending upon what the lesion is. And then you'll come up with your diagnosis, your interpretation. The Milan system is really not telling you how to interpret the FNA. What the Milan system is doing is telling you how to report your interpretation to the treating clinician, so that we're all using a uniform terminology. And by having a uniform terminology, we feel like the patient can go to any institution, clinicians at different institutions can communicate with each other, and ultimately it's going to lead to better patient care. So I like to show this example. This is an FNA, 3 different images of an FNA. We have Pap stain and we have Diff-Quick. It's a basaloid tumor. It's got a little bit of this matrix globules here. This is a classic basal cell tumor, and this illustrates the problem if you don't have a uniform reporting system. Some people may say, oh, it's a basal cell tumor. Some people may write 2 paragraphs or a novel about describing this. And others may give a long differential. Is it adenoid cystic or basal cell adenoma, blah, blah, blah. So there are many different ways that this basal cell adenoma could be reported. and that's why we need a reporting system to solve that problem. So the Milan system, it's a global effort. The atlas was first published in 2018, and we actually just completed the second edition. It's with the publisher right now, and we're expecting it to be officially published hopefully at the very beginning of 2023. If we're lucky, maybe the end of this year, but probably the beginning of 2023. And so what's new in the second edition of Milan? I'll show you the new risks of malignancy, but we have a much better handle on the risks of malignancy for each of the diagnostic categories, because now we have this terrific literature that's been published by all of you, and we can take that literature and extract the information and really hone in on the risks of malignancy. We also have a separate chapter, a new chapter in the next edition of Milan, which is dedicated to the imaging of salivary gland tumors. So that'll be a nice resource for all of you. We also have updated the ancillary studies chapter, so you really know what the latest markers are that everyone around the world is using to diagnose these different tumors. And we've really made the nomenclature in the book in sync with the new WHO for head and neck and salivary gland. So we're very excited that the Milan system has now been translated into both Japanese and very recently into Chinese. So we're really going global. Since 2018, there have been over 100 different cytology publications related to the Milan system, and they've been from countries all over the world. And these are the publications that we've used to, as I've mentioned, really hone in and refine the risks of malignancy associated with each of our diagnostic categories. Now, one thing that I would encourage all of you to do, and that is not only for the Milan system, but for the Paris system and all the other systems out there, we need to do a better job of communicating this information to our treating clinicians. And so I really, I'm begging folks to write articles and get them published in the ENT literature, for example, so that our treating clinicians understand the Milan system and how it's used, and then they can better use it to improve patient care. So as I mentioned a moment ago, we now have a brand new chapter that's included in the second edition of Milan. It's written by two radiologists at the University of Pennsylvania, Drs. Lazur and Garrett, and it's a very concise chapter, but they do a really great job of sort of boiling down the essentials of imaging, ultrasound, CT, and MRI, as it applies to salivary gland lesions, both non-neoplastic as well as neoplastic. This is just an example of imaging of a mucoepidermal carcinoma, but I think this nice little concise chapter is going to be a very good resource for all of us who are using the Milan Atlas. So these are the diagnostic categories in Milan. They have not changed. We did not change the names of them in the second edition. They include non-diagnostic, non-neoplastic, AUS, which is the atypical category. There are two neoplasm categories. One is neoplasm benign, one is neoplasm sump. We have suspicious for malignancy and malignant, and these two are pretty obvious. They're categories that we use all the time in cytology. Now, this was, as I say, it takes a village. This was a global effort, both in the first edition of Milan and the second edition of Milan. Together with Dr. Diana Rossi, who's just an incredible person to work for, We are the lead editors on this, but there are more than 50 co-authors from all different countries, more than 15 different countries around the world contributed to this effort, and both the first edition of Milan and the second edition of Milan. Dr. Zubair Baloch, really, my hat is off to him because he did a lot of work analyzing the new data that's out there, and then going through and calculating what these new risks of malignancy would be associated with each of the diagnostic categories. And he's the lead author on the first chapter of the second edition of Milan. These are the diagnostic categories and their risks of malignancy. I will highlight two of them. The neoplasm benign category, we definitely want to keep that risk of malignancy to be very, very low. And that's because some patients who are diagnosed with a benign lesion, even with a pleomorphic adenoma sometimes, may decide they don't want to go to surgery. And so if that's the decision, we want to make sure when we call it benign that we're pretty certain of that. The other thing is that the malignant category really, from the literature, it's 98%, but we want to be very close to 100% when we make a diagnosis of malignancy. The other thing I'll mention is that there is a 15% risk of malignancy for the non-diagnostic category, and that's simply because there's a sampling issue going on. There's a significant lesion there, and it just hasn't been properly sampled. But after that, most of these risks of malignancy increase as we go towards the malignant category. So let me just give you some examples now of some of the different Milan categories and how we use them. So here's one example, two images from one example. And just think to yourself, how would you diagnose this salivary gland FNA, this parotid gland FNA? It's a 50-year-old woman who has a 2-centimeter palpable right parotid mass. And you do your FNA and you get this. And basically what this shows is just completely benign, non-neoplastic, unremarkable acinar cells in these nice little grape-like lobular units connected by little hard-to-see ductal epithelial cells, intercalated duct cells. And here's an example of that on the right-hand side at low mag. Again, showing these nice, benign, non-neoplastic lobules of acinar cells. So if I get an aspirate that looks like this, and yet I have either a radiologically detected mass or a palpable mass, this finding really doesn't explain the mass. And in the Milan system, we would recommend that this be put into the non-diagnostic category because most likely this represents a sampling error. Now, if you really don't like using non-diagnostic for that kind of aspirate, you could maybe leave off the header or say that it's negative. But you very, very importantly, you need to put a note on your case that this finding of benign non-neoplastic salivary gland tissue does not explain the presence of a palpable or radiologically detected mass, and they need to do further evaluation and better sampling. Okay, so our non-diagnostic category, we would recommend in the Milan system that this non-diagnostic category not be used more than about 10% of the time. If you are getting a very high non-diagnostic rate, you should probably step back and take a look at, who's doing it, doing this. Should you be using ultrasound guidance or something? Because you don't want your non-diagnostic rate to be too high. The other thing is that in the first edition of Milan, we recommended that you needed to have about 60 cells present in order for your sample to be diagnostic. we got a lot of pushback on that, and we decided to take out that 60 cell requirement. And that's because we really don't have any hard factual information in the literature to say that 60 cells is a good cutoff. So we're really leaving it up to the individual to decide if their sample is adequate or not. However, I will say that this is an area where we need some of you out there to do research to tell us what should be the minimal criteria for a lesion to be diagnostic. So if you get an aspirate that's just normal, non-neoplastic salivary gland, or you just get non-mucinous cyst contents, those are all things that could be in the non-diagnostic category. So here's an example of an FNA in an 80-year-old male with a 4-centimeter left parotid mass. It's a pretty straightforward example where we have malignant appearing squamous epithelium in a background of tumor diathesis, and we have these, it's a keratinizing squamous cell carcinoma. This is something that we see all the time. This represents a metastasis of a skin squamous cell carcinoma, cutaneous squamous cell carcinoma, to an intraparotid lymph node. So this would easily be placed in the malignant category. FNA does a terrific job of diagnosing metastatic disease to these periparotid and intraparotid lymph nodes. Don't forget, all of the anterior scalp and the face and around the eyelids, all of that lymphatic drainage goes to, in part, the intraparotid and periparotid lymph nodes. And so you'll see metastatic squamous cell carcinoma from the skin, sebaceous carcinomas, Merkel cell carcinomas, melanomas, all of these going to the lymph nodes, and they are easily diagnosed by us doing an FNA. So let me say a few words, since we're on the malignant topic, about the malignant category in the Milan system. Obviously, these are aspirates where we are certain that we're dealing with a malignancy. When possible, you should try to subclassify your tumor into a specific type, and when possible, into a grade. Grading can play a critical role in guiding the management, as I described earlier in this talk. If it's high grade, there may be a very radical approach to the treatment versus something that's low grade. Other types of non-epithelial malignancies include lymphomas and sarcomas, and then, as I mentioned, metastatic disease. And it's not always possible to distinguish a primary from a met, but usually we have a pretty good idea. And if you're thinking about a metastasis, be sure that you get good clinical information about the patient. Do they have a history of a non-salivary gland cancer, especially, as I mentioned, a skin cancer? So our risk of malignancy for this category in the second edition of Milan is greater than 98%. And again, at my institution, and I'm sure at yours, you want it to be virtually 100%. Just a couple of examples of aspirates that on cytology alone we can call malignant. Here's an example. We have background mucin, we have goblet type mucinous cells, and then we have these epidermoid cells with higher NC ratio here and dense cytoplasm. So this is a classic example of low-grade mucoepidermoid carcinoma. We don't need any ancillary markers to diagnose this. We're going to come back to mucoepidermoid carcinoma in a few minutes when we talk about ancillary studies. Here's another example of an aspirate that has these large atypical cells present. Here's a low magnification view and a high magnification view on the left. You can at least call it malignant, and then with ancillary studies or possibly flow cytometry, you could identify it as a high-grade B-cell lymphoma. Now here's another aspirate. Hopefully everybody knows the answer to this. This woman has a 1.5 centimeter right parotid mass. Here's what the lesion looks like in the alcohol fixed pap stain. And here's the appearance on the air dried. So we have what some people call troll hair, or this fibrillar matrix with these bland little myopithelial cells embedded within it. And here in the air dried, it has this pink metachromatic appearance. So this is our standard pleomorphic adenoma. Most pleomorphic adenomas look like this. We have no trouble at all on FNA making a specific diagnosis. We don't need any ancillary studies to do this. And a majority, close to 70% of parotid gland tumors are going to be pleomorphic adenoma. And we can make a very specific diagnosis, classic pleomorphic adenoma, and that would go into the neoplasm benign category. So the neoplasm benign category, it's reserved for those lesions that we recognize as a neoplasm, and we also recognize them as a classic benign entity, including classic pleomorphic adenoma, classic Warthin tumor. Here's a Warthin tumor down here with these sheets of oncocytes in a background of dirty material and lymphocytes. Other things like lipomas and schwannomas would also fall into this classic benign category, and the risk of malignancy should be very, very low for this category. And I use the word classic because if it's a strange variant of pleomorphic adenoma, and we'll come back to this in a few minutes, I wouldn't put it into this category. I'd put it into the sump category. Now, this is an example of a woman who has a 2-centimeter left parotid mass. And those of you who do a lot of salivary gland FNAs are going to recognize this right off the bat as this pattern with this very fragile, abundant cytoplasm. It's fragmenting. You've got stripped nuclei in the background. These look like acinar cells. So I'm pretty suspicious that this is an actinic cell carcinoma. However, I would say without ancillary marker studies to confirm that, I would probably put it in the suspicious for malignancy category. If you're not real familiar with salivary gland FNA, you'd probably put this in the neoplasm sump category. Now, this is an example that I like to show because again, you might put this into the neoplasm sump category. However, if you had material for ancillary studies, you could do dog-1 staining, you could do molecular testing for the rearrangement, you could do the new NR4A3 immunostain. Any of these ancillary studies could be done to confirm that this is actinic cell carcinoma. And then, instead of calling it neoplasm sump, you can put it into the malignant category and say it's actinic cell carcinoma. And that's what we're striving to do. That's what our clinicians want us to do, so that they know when they go into that surgery, they're dealing with a malignancy. Because sometimes, even for low-grade cancers, the cancer is stuck up against the facial nerve. They don't know if they should sacrifice part of the nerve or not. You know, is it benign or malignant? They're not going to sacrifice the nerve if it's benign. So it really helps going forward. So just to summarize this neoplasm sump category, this is for lesions that we are certain it's a neoplasm, but a malignancy cannot be excluded. The risk of malignancy is around 35% for this category, and it's going to include many benign neoplasms that have some overlap with low-grade malignancies and some low-grade carcinomas. So it might include pleomorphic adenomas with squamous metaplasia, or remember I showed you that example of a basal cell adenoma would be in this neoplasm sump category. And the clinician's going to know and can tell the patient this classification means that you have about a 35% chance that we're dealing with a malignancy. But if it is malignant, it's probably going to be a low-grade cancer. Now, what do we do when we get aspirates like these 4 different cases where there's a little bit of atypia here, there's a lot of inflammation, we have a couple of large, look kind of like oncocytes. Here we have some crowded groups of epithelial cells, but they're mixed in with blood. Here we have a crowded group. I don't know what's going on there. And here, down here, we have these crushed cells with air drying, but again, they're atypical cells. I'm not really sure just from these images, am I dealing with a neoplasm? Am I dealing with something with very reactive atypia? What's going on? And so all of these examples would be things that I would put into that AUS or atypia of undetermined significant category. So it's for those FNAs where you're not sure if it's a neoplasm, but there is some degree of atypia present. And overall, the risk of malignancy for this category is fairly high based on the literature. It's around 30%. So most of these patients are going to need to go to surgery. Keep in mind that any salivary gland aspirate that has a lot of mucinous contents should be put into the AUS category because you can't exclude the possibility of a mucoepidermal carcinoma. Okay, so in the last few minutes, what I want to do is just describe some of the ancillary markers that we now have available and how they can be applied to salivary gland FNA. Really, over the last 10 years, we have just been very fortunate to discover new molecular profiles and immunohistochemical profiles for many of the salivary gland tumors that we deal with. I do not use ancillary markers on every salivary gland FNA case. In fact, I only use them on I'd say a minority of cases. They should be used judiciously on a case-by-case basis. But if you're dealing with a difficult salivary gland FNA, especially a neoplasm, that's when you can get material for a cell block and apply ancillary studies, and oftentimes that will help to give you a more specific diagnosis. This is not even a complete list, but these are some of the molecular changes, either mutations or gene rearrangements, that are now known to be characteristic of various salivary gland tumors, both benign and malignant. And I'm going to take you through a few of these in examples. So let me just quickly go through this algorithm. So you do a salivary gland FNA, you do a rapid interpretation, you recognize, oh, it's a pleomorphic adenoma. You don't need material for ancillary studies for that. Or it's chronic solidinitis. You don't necessarily need material for ancillary studies for that. However, on your rapid interpretation, if you realize, oh, this is going to be one of those neoplasm sump lesions, or I think it looks suspicious for malignancy, but I'm not sure, or it looks malignant and I'm not sure what kind of malignancy, that's when you probably want to do some extra needle sticks dedicated to making a cell block that could be used for immunohistochemistry. And if that doesn't work, if immunohistochemistry doesn't work to give you a definitive classification of your lesion, then you can use it for molecular analysis, which may be able to give you a better interpretation of your lesion, either as a benign lesion or as a cancer. So I just want to take you through a few of these different salivary gland tumors. One of the differential diagnostic considerations that gives us a lot of troubles are the basaloid tumors. And these include the cellular pleomorphic adenoma, the solid adenoid cystic carcinoma, and the basal cell tumor. So as I've already alluded to, we're very fortunate because a large percentage of salivary gland tumors, especially those in the parotid, are going to be pleomorphic adenoma. This is our friend. We recognize this. We do a great job. I'd say over 90% of pleomorphic adenomas can be specifically diagnosed by FNA without ancillary studies. In a small percentage of cases, pleomorphic adenomas can be cellular, or they could have metaplastic changes, such as squamous metaplastic changes, as we see here, or maybe sebaceous and mucinous metaplastic changes. And when that occurs, all bets are off. We're not sure anymore it's a pleomorphic adenoma, and that's when it's probably going to be in that neoplasm sump category. In terms of ancillary markers for pleomorphic adenoma, it's a tough one. PLAG1 and HMGA2 are two immunohistochemical stains. They're not great, but they can give you a little bit of help. PLAG1, it's not specific. I have seen other tumors of the salivary gland stain with PLAG1, but if I get strong diffuse staining, it does support that you're dealing with a pleomorphic adenoma. Of course, it would also be positive in a carcinoma X pleomorphic adenoma, but usually we can recognize that because the carcinoma is high grade. HMGA2 is more specific. It's a better marker than PLAG1, but unfortunately only about 20% of pleomorphic adenomas will be positive for it, and it's a nice nuclear stain. But if PLAG1 is negative and HMGA2 is positive, that's pretty good evidence that you're dealing with a pleomorphic adenoma. The other thing that you can do is molecular testing, looking for a rearrangement involving PLAG1 or HMGA2. Now, this is a quick case of an entity that we do not want to miss. This is an important entity to recognize by salivary gland FNA. It's a 38-year-old woman with a slowly enlarging neck mass at the angle of the jaw, tender to the touch. Anytime there's paresthesia or pain, we definitely worry about malignancy. So here's what the FNA looks like. We have these basaloid groups that are very solid, and this is actually matrix material out here. Here's a higher magnification view showing some of this matrix and showing these crowded basaloid groups. And this is probably the most useful image. We have the basaloid cells and with this very sharp outline around the groups of basaloid cells. This finding, even if it's a minor finding in your FNA, is very worrisome for adenoid cystic carcinoma. It's not definitive, but on cytology alone, I would automatically put adenoid cystic carcinoma into my differential diagnosis. And then the other thing is that in the air-dried preparation, we have, again, this sharp border and this pink metachromatic matrix, and we have the basaloid cells that are sort of smudgy there. But this also is a very concerning finding for adenoid cystic carcinoma. So if I were going to make a diagnosis based only on the cytomorphology, I would call this suspicious for malignancy, highly suspicious for adenoid cystic carcinoma. But that's not quite good enough. The clinicians could do a frozen section, but if we're able to make a specific diagnosis before they start the surgery, it's going to be better for everybody, because if you call it adenoid cystic, they're probably going to be doing a pretty radical surgery. So we actually did a repeat FNA on this case. We got material specifically for molecular testing, and we're able to demonstrate that there was a MIB fusion and confirm that this was adenoid cystic carcinoma before the patient went to surgery. The patient had a radical parotidectomy and partial sacrifice of the facial nerve with a nerve graft. All the frozen section margins were negative, and this is the patient's tumor showing a pretty classic cribriform type of adenoid cystic carcinoma. So adenoid cystic carcinoma, this, if we see this on our FNA, we're going to be thinking of adenoid cystic, metachromatic matrix with sharp edges and basaloid cells. Most of these will be placed either in the neoplasm sump or suspicious for malignancy category. There are some immunostains like CD117, MIB, and Notch that can be useful, but they're not specific. If you really want a specific marker for adenoid cystic, you want to do the molecular testing. I will say that we do use CD117. If you get this sort of strong diffuse membranous staining, it supports an adenoid cystic, and the same is true if you use the MIB immunostain, and I'll show you a picture of that in a minute. So you can do FISH analysis or PCR analysis to look for the MIB NFIB fusion, which would be diagnostic of adenoid cystic carcinoma, and it's present in a majority of adenoid cystic carcinomas. So generally, most often, it's the MIB gene fused with NFIB, and in a minor subset of cases, it will be a MIB analog called MIB-L1 fused with NFIB. There are alternate fusion partners that can be seen, but if you identify either the MIB or the NFIB, you know you're dealing with adenoid cystic carcinoma. The MIB immunostain does work pretty well. It's a nuclear stain, and if I see both diffuse MIB positivity and diffuse CD117 positivity, that's pretty strong evidence supporting an adenoid cystic carcinoma. But again, the molecular would be the definitive way to go. Just very quickly, I'll mention that whenever you're doing a salivary gland FNA, if you get a really high grade, sort of undifferentiated looking tumor like this, consider that you might be dealing with high grade transformation of a better differentiated tumor. And that occurs especially in actinic cells and adenoid cystic carcinomas, but it can also be seen in secretory carcinomas and epimesothelial carcinomas. The basaloid tumors, these are very difficult. They include basal cell adenoma and basal cell adenocarcinoma. Generally, they're going to be in the neoplasm sump category. This is the solid type of basal cell adenoma. If you do see a squamous morial, that can be a good clue on cytology that you're dealing with this entity. But you can have the tubulotrabecular variant like we have here with the little bit of membrane, with a little bit of membrane around the outside edge. That's a clue that you're dealing with that, but you can see how it can mimic adenoid cystic carcinoma. And this is an example of the membranous type. Nothing else in the salivary gland looks quite like this. It has this very thick ribbon of basement membrane material around the outside of the basaloid groups, and that's the membranous type of basal cell adenoma, but there's also a malignant version of that. The one thing I want to say about ancillary studies is that a large number of basal cell adenomas will have mutations in the beta-catenin gene. So you can either look for the beta-catenin mutation on molecular, or you can do an immunostain and look for nuclear positivity with beta-catenin, which is a sign that's supportive of a basal cell adenoma. Okay, just to finish up, mucoepidermoid carcinoma, as I've already mentioned, if you have an aspirate like this with goblet-type mucinous cells and epidermoid cells, that's a no-brainer. We can diagnose that as malignant. The problem is you have a low-grade mucoep and you do an FNA, and maybe you only get the mucin, or maybe you get an aspirate that has a lot of mucin and just a few bland epidermoid cells. Those can be very, very difficult to classify. Immunohistochemistry is not very helpful for mucoepidermoid carcinoma. The one thing I would say is that if I have a cell block, I would want to look and see if I have a combination of mucin positive cells as well as P63 positivity in the scattered epidermoid cells. But again, not a specific immunoprofile. The best thing is molecular, and this is probably the most common lesion that I apply molecular testing to, and that's looking for the MAML2 gene rearrangement in mucoep. And these are 3 different salivary gland FNAs that were in the neoplasm sump category, but we did molecular testing, and all 3 had the MAML2 gene rearrangement, and we were able to take them out of the sump category and call them malignant mucoepidermoid carcinoma. And that's what we want to do to make salivary gland FNA more relevant, more useful for patient management, and more accurate. Actinic cell, I've already alluded to this. This is a classic cytology of actinic cell. If you do immunostains, that's usually good enough. They're strongly positive for DOG1 and SOX10, as well as that new antibody, the NR4A3 antibody works great. So immunochemistry can be done, or you can do molecular looking for this gene fusion that's present in a majority of actinic cells. Secretory carcinoma, aspirates look kind of like a actinic cell, but they tend to have a little more vacuolated cytoplasm. Again, this is one that's going to be in the SUMP category based on cytology alone. However, the immunoprofile is fairly specific. They're positive for GATA3, S100, mammoglobin, and GCDFP15. So if you have a cell block and you get this immunoprofile, you can be pretty confident that you're dealing with a secretory carcinoma. The immunoprofile does overlap with intraductal carcinoma, but again, it's two carcinomas with overlapping. However, the most specific ancillary test would be to actually do the molecular, showing that there is this gene fusion involving the NTRK gene. And keep in mind that this is important because NTRK can be useful as a therapeutic target. The last thing I want to say is this case, an 80-year-old man who presents with right facial paresthesia. Again, we're going to be worried about malignancy. 3-centimeter parotid mass, and the FNA is done. Here on the air-dried preparation, we have these big, ugly cells. So this is a high-grade malignancy. Here's a Pap stain and another view of the air-dried. So we're going to put this into the malignant category. It's a high-grade carcinoma. So malignant, high-grade. Now, if you have a cell block, you can go a little bit further than that. In this cell block, it was positive for GATA3 and androgen receptor, and also showed overexpression of HER2/neu. And so this is diagnostic of salivary duct carcinoma. And don't forget, if you're dealing with salivary duct carcinoma, the HER2/neu overexpression, your oncologist will probably want to know about that, because these patients are sometimes being treated with Herceptin, just like in breast cancer. So your diagnosis is malignant, consistent with salivary duct carcinoma. So just to summarize, we're very happy that the Milan system is continuing to gain global acceptance as a uniform salivary gland FNA reporting system. I'm looking forward to the publication of the second edition of Milan, where we have really revised risks of malignancy. We have an imaging study chapter. We have new ancillary studies that are up to date. We have nomenclature in sync with the new head and neck WHO, and a new emphasis on expression profiles and how they can be useful as treatment options. So I hope I've convinced everybody of the value of salivary gland FNA, and also the value of a uniform reporting system, the Milan system. Thank you very much.
Thank you very much to you, Bill, for this very extensive presentation. So the book will be out at the end of 22, beginning of 23. And then I imagine that we have to go to our clinician to explain what's new, to explain that we use this system because it's really useful and because they have new and based on literature risk of malignancy.
Yeah.
So do you have any tips to suggest us when we go to present the new Milan system to our head and neck clinicians?
Yeah, so well, this presentation and others are available online, and there's also a Milan system website where folks can access information about it that can be used when you do a presentation for your treating clinicians. I like to emphasize examples like I showed you today, where when we do an FNA, we can actually get extra material and do these ancillary studies so that we can actually tell the clinician before they go to surgery exactly what they're dealing with. And we can, most of these tumors now have specific or characteristic molecular profiles that we can identify. And so I'd also say that we can emphasize that FNA is very nicely complementary with frozen section. So all of this is going to help the treating clinician to know what they're dealing with, and then to provide better patient care. So those are the messages. But again, there are images on the websites that folks can access.
Thank you. And I have another question before looking at the chat. You showed the algorithm to follow in case you do a rose. So ask for an extra pass to perform cell block or to perform flow cytometry. If you don't have a possibility to have a rose, and if you are in your office and you get just a liquid-based sample and you need more material, do you think that colleagues will do an ultrafine needle, or we prefer to move to surgery with frozen section?
Yeah, that's a great question. I think it depends on the overall radiologic and clinical findings, and whether the treating clinicians think that they may be dealing with something that's aggressive, where they're going to want to sacrifice the facial nerve and do a neck dissection. So in cases that we've had where they thought that they were going in to do something potentially very radical, they really wanted to know the answer before they started that surgery. And so they would either do a repeat FNA, or in some cases they might decide to do a core biopsy to make sure they get material for good ancillary studies. If they're dealing with something that's very well circumscribed, they're not worried that they're going to have to do a radical surgery, they may not do a repeat FNA. They may just go to surgery and probably do a frozen section at the time of surgery to confirm that it's a pleomorphic adenoma or Warthin tumor or something like that.
Thank you very much, Bill. Other question from the chat. A lot of greetings for your presentation. Thank you, Bill. And you have also, the Milan system is also followed in Pakistan, where they use it and they're very happy. And someone is asking if you can use slides for molecular study in case you don't have a cell block.
Yeah, well, you know, that it certainly is possible to scrape material off of glass slides and do molecular testing from that. We have experimented with that in our department, and we have gotten it to work. I know other places have gotten it to work. There are publications in the literature about doing that. But the thing is that you're going to have your molecular lab in your pathology department, or wherever you're sending your material for molecular analysis, you're going to have to make sure that they are used to dealing with material scraped off of a glass slide. But yes, it is an option. It can work. And again, you know, some places just may not have the ability to do molecular testing, in which case you do the best you can with cytomorphology alone. We can do a pretty good job on cytomorphology alone, and the Milan system does have the SUMP category, and at least the clinicians know, okay, this is a lesion, 35% chance of malignancy, but probably it's going to be low grade, and they pretty much know what to do based on that.
Okay. Another question concern salivary gland-like tumors in other localization, skin, breast, sinonasal, lung. Do this tumor have the same immunohistochemical profile of salivary gland lesion in salivary gland?
Yes. So what I think about is are like adenoid cystic carcinomas, mucoepidermoid carcinomas, epimyopathial carcinomas that can occur in the breast, in the skin, pleomorphic adenomas in the skin. All of them in the different locations, they tend to have the same molecular profile. There are exceptions where now we know that some of the adenoid cystic carcinomas in the sinonasal cavity, for example, do not have the mammal-2, the MIB rearrangement, and so they're HPV positive. So those have now been redefined as the HPV-related multiphenotypic carcinomas. So there are examples where we find out when we do molecular analysis that it's actually a different entity. But I would say that your usual mucoeps and adenoid cystics and epimyoeps will have the same molecular profile in different anatomic sites.
Okay, thank you very much, Bill. There are no more questions in the chat, so I would like to thank very much you, and also to thank Alison Austin from the International Academy of Cytology Central Office for the technical help. And this is to inform all attendants that the following speaker will be Lukas Bubendorf from Switzerland about the new version of the Paris system. So stay tuned on the website of the International Academy of Cytology for news about other webinars. And Bill, thank you very much. We are looking forward to the new Milan system. Thank you very much.
Thank you very much. Bye-bye.
Bye.